All right, welcome everyone to another shadowing session here at Hearts for Health. Today we are joined by Dr. Chevinsky. She's a double board certified preventative medicine and lifestyle medicine physician serving as Deputy Public Health Officer for Riverside County Public Health. So we are actually really excited to talk about this special today. It's not something that we've talked about before. Preventative medicine is a new arena within healthcare, and we're trying to shift on over to that. So we're excited to talk about it today. A few reminders for those who are new. Towards the end of each of these sessions, we will have a Q&A. So feel free to type in any questions you have in the chat box. I'll read out those questions for Dr. Chevinsky to answer, and we'll hopefully be able to get through them all during the Q&A. Also, to stay updated with future shadowing sessions, follow us on Instagram, where we post our flyers for each shadowing session. These are on roughly a Monday and Thursday schedule at 7 p.m. Central. Sometimes it does fall outside of that, so it's a good idea to keep in tune with when those will be and what specialties they'll be with, speakers and all. That's all included on our flyers when we post them on Instagram. Another way to stay in tune with us, you can go either way or both, is through our email listserv, where we post announcements over email weekly on Tuesdays, usually Tuesday morning. We'll include flyers and posts, announcements in general about virtual shadowing, along with a few other programs. Both are great ways to stay in tune with us. Both are great ways to get contact with us over virtual shadowing and our other programs. We have a clinical volunteering program, a refugee teaching program, and we're actually just releasing now a mentorship program. So if you want to get involved in any of those, I recommend scrolling through our Instagram page. Outside of that, that's all I have to say. Later on, at the very end of this session, I will talk more about the quiz, which is how we allow you to receive credit and recognition of your attendance. There is that quiz, and you'll have to pass with a certain grade. So I'll comment more on that later on. But for now, Dr. Chevinsky, feel free to take it away.
Thank you. And thank you for inviting me to be here and to speak with everybody about preventive and lifestyle medicine. I know that it's not necessarily areas that everybody has exposure to in their undergraduate or graduate medical school studies. So I'm hoping that I can help create a couple more preventive and lifestyle medicine physicians by the end of this, or those that are interested in careers in public health. As Michael mentioned, I am the current Deputy Public Health Officer with Riverside County, and I'll share a little bit more about my role later on as well. First, I'm going to start off just to open your eyes to some of the realm of what preventive lifestyle medicine, public health, what we might be doing. So this is just a recent news clip, and please let me know if you're not able to hear it when I share it.
State, county, and community leaders are coming together to work on the local response to a growing number of monkeypox cases. There's one confirmed case and 5 probable cases in the Coachella Valley. News Channel 3's Samantha Lomival live in studio. An update on local efforts to make more vaccines available for people who've been exposed. Samantha.
John, in tonight's meeting, there were many questions regarding how many vaccines are available here in the Valley and who's eligible to get it. Now, county health officials said they are working very closely with local health providers to get as many doses out to those who need it.
Essentially, it comes to the point of there's much more need than there is vaccine.
In order to increase vaccine availability, the county says it's working with local partners.
We navigated with DAP Health.
So that was just a start. There's a longer video clip, but just to give an idea, the media working with different partners, working on new outbreaks. And so it's a field that perhaps you've been hearing a little bit more about in the past couple of years than perhaps people had been hearing about prior. But sort of giving you a look at behind the scenes, who is doing this work.
And how
So today, what educational background and career background, in case it is helpful for anybody's listening. to think about what kind of opportunities that they might want to seek out if they're looking for a career in preventive medicine or public health. Then I'll talk a little bit about the field of preventive medicine, a little bit about the field of lifestyle medicine, about careers in public health, and then we'll go through some cases and we'll do a Q&A. Please feel free to add any questions in the chat. While I won't be monitoring it during the presentation, Michael and his team will be, and so they'll be bringing those questions forward to me at the end. So as far as my educational and career background, my undergraduate studies I did at the University of Connecticut. My major at that time was bioethics and cross-cultural perspectives. So it was a combination of more of the science, biomedical side, as well as philosophy, anthropology, and some of the social sciences. And with that context, I also did a number of different experiences and internships, including at UNESCO in France in their bioethics division, as well as at Georgetown and at Yale. So it really started with an interest in medical ethics, in bioethics, in health justice, in health equity. And that was the start of my interest in avenues towards public health, but at that time it had been more bioethics related. And then for medical school, I went to University of South Florida Morsani College of Medicine in Tampa, Florida, part of their SELECT program. So it's the Scholarly Excellence Leadership Experiences Collaborative Training Program. That's what it's called. And it's a program that is 2 years in Tampa, Florida, and then 2 years in Lehigh Valley in Allentown, Pennsylvania. And the program is focused around healthcare leadership, around health systems, patient-centered care. So much more of a broad view of healthcare than perhaps it might be seen in other kinds of medical schools. So it attracts people that have more of those diverse interests and are thinking about maybe healthcare leadership at an earlier stage. And while I was in medical school, a couple of different experiences that I had there between my first and second year of medical school, I did an experience at Oxford and University of Warwick in England, building a medical education curriculum on what was called values-based practice, which was how do we incorporate patients' values into the care that we are partnering with them on. And so it was a curriculum that was then put in place, parts of that at University of Oxford, at Warwick, and then back at my home institution as well. And out of that and other initiatives grew a values-based practice center at Oxford as well. And then I also, in my fourth year, did a couple of away rotations. And so for those that are thinking about, if you're thinking towards a career in public health or in preventive medicine, starting to think about what rotations you can do that might help you give that view. And that's similar to other specialties that might not be as heavily covered within your typical medical school education. So some of those other programs that might not be part of the core curriculum, you might need to seek out some of those rotations. So one of the rotations that I did was at the institute. Focus of that was international public health. So we were based at a number of different rural health clinics, providing not only the parts of the clinical care, but also assessing nutrition and talking about other kinds of things like women empowerment or policy issues that were facing the population. So it was a much, again, broader view. And I think back to the head of the clinic there, the person who first started the institute. What he had said is that initially what he was planning to build were some clinics. He realized that the care there, that there needed to be more clinical care. There needed to be options for people who were having trouble finding healthcare. And when he created these clinics, originally, he started to see patients that would present with these similar issues over and over. And those similar issues were tied back to poverty, and they were tied back to not having the appropriate nutrition that they needed, and infections that were also related to living situations. And what he realized is if he didn't deal with, or if he didn't put into practice things that would help with the public health components, with the society components, with the social determinants of health, that he would see the same clinical issues over and over again without fixing the root of the problem. And that's something that stuck with me throughout my career as well. Then I did a rotation with the CDC. They have an applied epidemiology rotation. It's called an epi elective that medical students and veterinary students can do. And with that one, I was placed within the National Center for Chronic Disease Prevention and Health Promotion, and it was in their cancer branch. While I was there, I also had the opportunity to do a deployment with the Epidemic Intelligence Service officers who were there. The deployment was to Arizona, Maricopa County, because they were having a outbreak at that time of West Nile virus and St. Louis encephalitis virus. And those were two viruses that typically they're vector borne, meaning they're spread by mosquitoes. And typically you would get one in a season or you would get the other, not both at the same time. So the investigation was to better understand how are we seeing both of those at the same time when we're seeing patients percent. How can we differentiate the two? And how can we ensure that we have the proper laboratory testing in place to be able to differentiate the two? And so it was an opportunity for me. It was one of my first looks into how multidisciplinary teams can be formed, not only within the scope of clinical medicine, also partnering with institutions, with lab professionals, with skills in different areas, with epidemiologists to help address a problem that has multiple different aspects, that has many community parts in order to be able to help address it. Then for residency, I did my transitional year at Lehigh Valley Health Network. So it was the same place where I did my second 2 years of medical school. And during that time, I set up a rotation with ABC News in their headquarters in New York with a focus on health journalism. And they still have a similar rotation. So if health communications, health journalism is something that is interesting to you, that might be something that you would consider doing. For me, it was a really great experience to have some training and understanding of what makes the news and why does it make the news, and how do we do proper reporting, and how can you link your studies, how can you communicate them better to different populations, the way that people can understand it, highlighting the key findings. And so I was able to write a number of articles for ABC News, draft scripts for their videos. And so that might be something that would be interesting to others here listening into. Then for my preventive medicine residency. So the way that preventive medicine residency works is first, if you're doing what's called the categorical way, you would have to do 1 year of some base clinical training. So that can be a transitional year, that can be a prelim year, or it might be in one of the other clinical specialties. Some people do that and then and end up transferring into preventive medicine. But it's a 1 + 2 years of preventive medicine residency training, or some people might do it as a fellowship or as a secondary residency on top of their core residency. With preventive medicine residency, you have rotations that are in a number of different topic areas. Typically, you might rotate at a county health department. You might also rotate at a health insurance agency. You might be doing things like quality improvement projects. And you might also have some clinical preventive medicine work or occupational medicine work that you're doing as well. And that training is also paired with an MPH degree, a master's in public health. For me, my MPH is in population medicine, but others might have other subspecialty MPH areas. I did my training at Loma Linda University, that's in California. And it's at the location of Loma Linda is known as being a blue zone. So if people have heard of the blue zones, they're areas that have been identified throughout the world where they have a large portion of their population who are centenarians as well. So people who live past age 100. And so it was an area to also learn about lifestyle medicine as well, and some of the things that are helping those populations to live long lives. And we'll talk a little bit more about that later in the presentation too. During my time in my preventive medicine residency, I also did a rotation with the U.S. Preventative Services Task Force, so USPSTF. In combination with ARC, or the Agency for Healthcare Research and Quality. Those are government organizations, and USPSTF is non-government, but there's collaboration there with ARC. And they're the ones that help set the recommendations, like for breast cancer screening or for colon cancer screening or for prostate cancer screening. And so that was a training experience in health policy. So similarly, some of you on the call might have interest in one of these areas like communications or health policy or epidemiology, one of these areas, maybe not all of them. So you can take, that information about those experiences with you. And some of you might be listening and thinking like, wow, look at this diversity of kind of work that you can do if you enter the field of preventive medicine and public health. And that's exactly what I'm hoping to highlight, is that for those that maybe are going through medical school and they're going through their rotations and they're finding, you know what, I kind of like this all, but I'm looking to work maybe at more of a population level. Preventive medicine might be something that you would want to consider. Then for my fellowship, I completed my fellowship at the CDC as an Epidemic Intelligence Service Officer. And during that time, I was within the return back to the National Center for Chronic Disease Prevention and Health Promotion. But that time I was with the Division of Nutrition, Physical Activity, and Obesity, or DNPAO. But when I had started, it was actually right before a couple of key events. So the first one leading to deployment with EVALI, or the e-cigarette or vaping associated lung injury. So some of you may recall when there started to be reports of cases of people that were having this mysterious lung injury, and it wasn't clear what it was linked to. When we first started to get reports of that, I've been one of the individuals that was deployed to Chicago, where a number of those cases were being reported, to help investigate what actually was going on there. So looking through electronic medical records, healthcare charts, to try and identify what were the common symptoms, what were the common radiologic findings, what were the common laboratory findings, and so trying to define and make the classification, building the case definition of what is EVALI and what is the cause of that. Then after that was right around the time that we started to hear about COVID, or at that time, what we called nCoV, the novel coronavirus. So I was one of the first medical officers that was deployed to the airports. So I was deployed to San Francisco International Airport as a quarantine medical officer. And my role there was I was helping with screening people that were coming off the planes from Wuhan. So back in the early days when we were screening some of the travelers that were coming in. So I was there for a couple months in San Francisco, and then redeployed to JFK Airport in New York to similarly do screening. But at that time, it had widened to a 24-hour operation, as it was not only screening people that were coming in from Wuhan, but then also from anywhere in China. And then I had a few more deployments after that as well. So one with the International Task Force, and with that, I was helping to build a database of mitigation efforts that were occurring across the world globally. So that was a lot of work with talking with different stakeholders, like leaders of ministries of health, to understand what kind of practices they have in place to try and protect the population against COVID. And so the work that we did to identify, when they were doing lockdowns or curfews, or limiting other kinds of mobility, or putting other sorts of things in place, we would document that, record it in a database, and then try and see, did those different practices actually help the spread? Did they see a drop in their spread after doing those different practices? And that initial database ended up entering the World Health Organization database, off of which a lot of the modeling efforts have been conducted to identify what strategies work versus which strategies may not work as well. Also, within that deployment, built some resources for rural areas, international rural areas, to help train community health workers there on how to use oxygen tanks. So if you search the depths of the CDC videos, you would probably find a video of me acting, probably poorly, but showing how deliver oxygen and to set up the tank, train somebody so that they can watch those videos and quickly be able to better understand how they could use oxygen for patients that might need it in their clinics. I was also involved in some of the efforts around cruise ships. So early on, you might recall some of the cases or outbreaks that happened on cruises. And so for one of those cruises, I helped with doing the contact tracing, calling the people that were on board the ship. I tried to get an idea of who was sick, who was not sick, who they were exposed to, what events they went to. And then after that was deployed to the data analytics and modeling team. And with that, conducted analyses primarily on electronic health records, looking at big databases. Things like what was linked to readmissions for COVID, or that was with after their initial bout of COVID. And that sort of led into my work being worked on what now most people know as long COVID. And so in that deployment, I led the authorship of the interim guidance with post-COVID conditions or long COVID. So if you look at the CDC guidance talking about long COVID, that was an effort of bringing together multiple specialists across the country that were working in long COVID clinics, as well as patient advocacy groups, people experiencing long COVID, gathering that information together as feedback on the guidance that we were putting together, and then doing presentations and other putting together other efforts to get that information out there. In terms of my current role, so I'm the Deputy Public Health Officer, as I mentioned. I oversee the Division of Infectious Disease, Community Health Planning, and Health Equity. And within that division, we have our Public Health Laboratory, we have our Epidemiology branch, we have our Communicable Diseases branch, and we also have our HIV and STD branch. I also oversee our medical education programs, and I treat clinically, I treat patients with tuberculosis, active and latent tuberculosis. I served as the medical advisor for our COVID-19 response, and now as a medical advisor for our monkeypox response. I also serve as an assistant professor for Loma Linda University in their preventive medicine department, and as an editorial on the editorial board and as a reviewer for the American Journal of Preventive Medicine Focus Journal, and I'm on the planning committee for the American College of Preventive Medicine Conference. So part of what I hope you see through this presentation is sort of what I hinted it to you a little bit early on, is with preventive medicine, you have an opportunity for a lot of diversity of work and collaboration with different partners. So that might include something like news reporting on Zika, which I was able to do when I was at ABC News, or building an alcohol misuse screening system for a large managed care organization, or putting together health policy reports for Congress, or deploying to airports as a quarantine medical advisor, creating CDC interim clinical guidance. I had the opportunity to testify in front of the California State Senate. I've been involved in training local promotoras or community health workers who specifically work with the Latinx community, and have been real leaders throughout the COVID response in terms of getting information out to communities, creating local therapeutics program for COVID treatments, or partnering with faith-based organizations on creating a pastor's toolkit, which was information about COVID specifically for people that were affiliated with different faith-based organizations, clinically treating patients with tuberculosis, or now something that I've been heavily involved with in terms of creating vaccine prioritization strategies for monkeypox vaccine. So in these next sections, I'm going to talk a little bit more about this specific career. So a little bit more about preventive medicine, lifestyle medicine, public health. So first, preventive medicine.
Dr. Chevinsky, I think it might be breaking up just a bit. Let's just wait for.
Able to hear me?
Yeah, we can hear you. It's just breaking up in and out. The connection seems to be fading sometimes.
Is the connection better now?
Yeah, it's slightly better, somewhat breaking off. Do you think maybe if you rejoin in on the meeting might help?
Let me see, or I might be able to switch my network.
Yeah, either one.
All right, does this seem a little bit better?
Yeah, perfect.
Okay, so in terms of, what is preventive medicine? I'll go back. So preventive medicine is the practice of promoting preventive healthcare to improve patient well-being. The goal ultimately is to prevent disease, disability, and death. Preventive medicine specialists are licensed preventive medicine physicians, and lens, but talking about the board certification around preventive medicine, it's physicians that go through the residency training and then get the board certification. We evaluate and administer preventive treatment that is derived from possessing expertise in a broad range of healthcare skills. So that might include biostatistics, epidemiology, planning and economic and behavioral sciences in order to improve the health and quality of life of individuals, families, communities, and populations through disease prevention and health promotion. So it's very broad, and preventive medicine physicians work in many different spaces. So I put a link on the bottom here, but if you're not able to access the link, you could also search Kevin MD for, and the article that I wrote is the best medical specialty you've never heard of. And of course, that was my perspective. That's still my perspective, but many people probably have not heard of preventive medicine. And it talks about all the different kinds of things that you could do with the field of preventive medicine. And then at the bottom below that, I also linked the American College of Preventive Medicine, which also you could Google if you're interested in. It's or ACPM, which is the main main college or association for preventive medicine physicians, and it has a lot of great resources as well about the field of preventive medicine. Within preventive medicine, there are a few different core specialty areas. So I'm going to talk about each of those. This first one is the one that I'm boarded in and that I practice. But I also, in case you didn't, you might not have a chance, or you don't get the speakers in the other areas, or perhaps it's an idea of getting those speakers in the future. I'm going to also outline what those other subspecialty areas are, just for awareness. So GPM, that's the general preventive medicine, public health and general preventive medicine. And so that's a specialty area, focuses on promoting health and preventing disease in individuals and communities. And we combine skills and experience in clinical care and public health to support the transformation of health systems and to rebuild them based on prevention of diseases, injury, and death. So we might work for corporations. Some people work in primary care settings, in public health departments, in government agencies, other settings, like I mentioned, health insurance companies, or health tech, startups. There's many different realms. And the goal is to impact healthcare delivery and health outcomes at the individual, practice, community, and population levels. Another specialty area within preventive medicine that you can also get boarded in is occupational medicine. And occupational medicine focuses on the physical and mental health of workers by seeking to improve the physical, structural, and social conditions of the workplace. And they work with both small businesses and large corporations to design employee health plans, to improve workplace safety in hazardous environments, and to promote health and quality of life in the workforce. And then a third specialty area is aerospace medicine. And so aerospace medicine focuses on the health, safety, and performance of crew members and passengers of air and space vehicles, working closely with support personnel who assist in their operation. And they often live and work in remote locations, in extreme environments, and they're working with difficult conditions of physical and psychological stress. And their goal is to promote preventive care medicine, even in the harshest environments. And they strive to improve health and do so in settings with many unique hazards, not necessarily found in other work environments. And so those are some of the core specialty areas within preventive medicine that people might go into. Next, I'm going to talk a little bit more about lifestyle medicine. And that's the second area that I'm boarded in, whereas the first one is ACGME accredited. The lifestyle medicine, while it's gaining traction, it's not yet at accreditation, but there are growing programs in that area, and I'll talk a little bit more about that. So what is lifestyle medicine? The idea behind it is to advanced evidence-based lifestyle medicine to prevent, treat, and reverse non-communicable and chronic disease. It's a medical specialty. It is therapeutic lifestyle interventions as a primary modality to treat chronic conditions, which may include cardiovascular diseases, type 2 diabetes, but that's just a short list. There are many different areas in which lifestyle interventions could help to either halt, reverse, or improve clinical conditions. Lifestyle medicine certified clinicians are trained to apply the evidence-based whole person prescriptive lifestyle change to treat, and when used intensively, and in some cases, and depending on the disease, often reverse such conditions. And it's based around 6 pillars. And so the 6 pillars of lifestyle medicine are a whole food, plant predominant eating pattern. So that one sort of ties in with some nutrition components, physical activity, restorative sleep, stress management, avoidance of risky substances. So certain drugs, alcohol, smoking, things like that, and positive social connections. And these also tie quite well to some of the findings from the Blue Zone studies, or studies looking at what leads to populations living longer and healthier lives. So not only, about the length of life, but also the quality of life, and living with context of wellness. These are some of the principles that have been found and continue to be linked to living that, or to help with managing many different kinds of diseases. And so I linked here also the American College of Lifestyle Medicine, which is one of the leading organizations in lifestyle medicine, if that's something that reaches out to you. And that's something that I received training on when I was at Loma Linda. I got the board certification, but it was something that clicked with me because I would think back to my days in clinic, or in medical school, or in my transitional year. And you might be at a clinic and you would see people that are coming in with diabetes, for instance, and they're continuing to get worse and worse and worse, and we're upping and upping and upping their medications. But there might be opportunities to address what some of these factors might be, and we'll talk a little bit about that later as well. So a little bit more about lifestyle medicine. So the premise behind it is that lifestyle medicine can address up to 80% of chronic diseases, because many of the chronic diseases that we see nowadays are based on lifestyle factors. And when I say that, I don't mean that it's an individual's responsibility or their fault necessarily, but what I mean is that that those lifestyle factors are linked to chronic disease, but they might be impacted by the environments that people live in as well. So, for instance, if they're living in a food desert where the closest that they have is a convenience store, but they don't have a supermarket, then that might impact the food choices that they have, and thus the food that they eat, and thus the disease that they might present with. Similarly, in areas where it might be more predominant to drink sugar sweetened beverages like sodas or sweetened iced teas and things like that, it's not necessarily fully just based on what the individual is doing, but the environment where they are living, the policies that are in place, what the neighborhood situation is that might influence what those decisions or what those choices are, because we can really only make decisions or choices based off of what is actually available to us. So the lifestyle medicine approach to population care has the potential to arrest decades-long rise in the prevalence of chronic conditions and their burdensome costs. Patient and provider satisfaction often also result from lifestyle medicine approaches. And I think part of that is because of addressing some of the causes, but another part of that is lifestyle medicine visits typically are a little bit longer. So in primary care, for instance, where you might interact with similar kinds of patient population, you might only have 10 or 20 minutes to actually talk with them, and you might not have as much time for the counseling part or the behavior change part or the motivational interviewing part. In lifestyle medicine, typically those visits are longer to allow for more in-depth conversations to explore what the person's life is actually like, what stressors they might be experiencing, and to really build that trust to have those conversations and make those small incremental changes over time. And so this also strongly aligns with what may be called the quintuple aim, is how the American College of Lifestyle Medicine puts it on their website, which includes better health outcomes, lower cost, improved patient satisfaction, improved provider well-being, and also advancement of health equity, in addition to its alignment with planetary health. Lifestyle medicine is the foundation for a redesigned, value-based, and equitable healthcare delivery system, leading to whole person health. That's the idea behind it. So now I'll switch over to the public health physician. And, my career path sort of aligns in different ways with each of these three areas, but kind of unites in some of those core skills. So now we'll talk a little bit more about being a public health physician. So a public health physician is a highly trained physician who focuses their efforts on improving the health of an entire population instead of just a one-on-one patient treatment. And while preventive medicine is one pathway into being a public health physician, there are certainly other specialties, people with other specialties that end up in public health. That might be people who do a residency in pediatrics or in medicine or internal medicine or ER or just about any other specialty. They might decide to go into public health to have a broader impact at the population level. The primary focus is on prevention of disease within a community, and there are numerous responsibilities that somebody might have within the position, which might include gathering data to analyze and assess public health problems, conducting research related to those problems, including their possible causes and links to other issues in the community, developing strategies that can help lead to the implementation of programs that will prevent disease or promote good health overall in the community. As we know, the one-on-one care, of course, that's crucial, but we need to be thinking at systems level when we're trying to better the health of populations across the board. And then also consulting with public health officials to develop legislation that focus on improving the health and well-being of entire communities. So we're going to move into some case studies, and I haven't been keeping full track of time, but I think that we're going at a pace that will allow for some questions at the end, certainly. All right, so we'll start with this one, and I'll ask you guys, although I can't see it in the chat, you can put your answers in the chat. So we'll start with this one. A 16-year-old male with dyspnea arrives to the ED with a 3-week history of dyspnea, dry cough, fevers, and night sweats. 2 weeks previously, he was evaluated in an outpatient clinic and given a course of azithromycin for presumed infectious pneumonia. He states that he feels miserable, has severe nausea and vomiting, and hasn't eaten in several days. His only medical history is childhood asthma, and he reports no surgeries and takes no medications. He has no risk factors for HIV. He doesn't smoke combustible cigarettes or use IV drugs and hasn't recently traveled. On examination, it shows a room air saturation of 89%, temperature of 38.3 degrees Celsius, and a respiratory rate of 22 breaths per minute. And before people put their answers before I finish, if you guys have guesses, if you're trying to compete and see who gets the answer first. Results of his examination are normal, and there are no rails or wheezing current in the lungs. Chest radiograph shows bilateral consolidative opacities. White blood cell count is 14,000 with left shift, and results of biochemistries are normal. SED rate is 104, procalcitonin is 0.08, urine tox screen is positive for THC. When asked specifically about vaping and e-cigarette use, he reports that he recently began using THC cart that his friend gets from an unknown supplier. So what's the diagnosis? And I think many people will probably get this one because I left a lot of hints towards the end. And it's something I referenced a little bit earlier on. But yeah, this one is convincing for EVALI or e-cigarette or vaping associated lung injury. And I put a link here and this is just the case that I pulled from, because actually we saw many, when I was deployed, we saw many situations of people that look very similar to this kind of description. But what I want to focus on here is not necessarily the diagnosis. This is kind of a little bit of a decoy because the public health question is, but what do we do next? We have one person that we've diagnosed with EVALI, but in public health, we think much broader than that. We ask, are we seeing a pattern? Is there an outbreak? So if we're considering there to be an outbreak, then we're going to be doing some outbreak investigations. And so there's a guide to how we conduct these outbreak investigations. You need to start by preparing for the possibility of field work, of having to do deployments or pushing people out to the field to better investigate what's happening, not only in one hospital, but in many hospitals or multiple hospitals seeing the same patterns. We're trying to establish the existence of an outbreak. So is this truly something different than what we've seen before? Are there more cases than what we would expect? We try and look at the numbers, look at what we're seeing, and to identify, is this truly an outbreak? We have to verify the diagnosis. So sometimes that takes lab studies to verify. We work on constructing a case definition. So what aspects are needed in order for us to say that this is EVALI? Do they have to have said that they had a history of smoking THC? Do they have to have shown something radiographically on their chest x-ray? Does it have to be certain labs, or are there exclusion criteria? So that's all built as well. We work on finding cases systematically and recording that information and performing a descriptive epidemiology. So is this something that is only happening in males? Does it happen in males and females? Is it happening more so in certain race groups or ethnicity groups? Or what about gender identities or sexual orientations? All of that is important for us to better understand who is at risk and who is being affected. We develop hypotheses, and then we evaluate those hypotheses epidemiologically. We reconsider, we refine, and we reevaluate those hypotheses. And then we compare and reconcile with laboratory and environmental studies. So are we able to do studies on, one of the things that we worked on with the EVALI is trying to get anything that was left of the product that people were smoking when they developed EVALI. And so we were asking them, send us your cartridges, send us your products, send us what you have, so that way we can test them and see, is there something different about the product that you're using compared to what other people are using, such that you got sick, other people didn't get sick. We implement control and prevention measures, and we initiate or maintain surveillance, which means once cases start to trail off, well, we still want to have something in place that would be able to identify if they pick up again. So that might be things that are initially when cases are high, we might have people doing direct report to the health department. So we might reach out to them and have more active surveillance. Or we might do more passive surveillance, or we might build surveys where each year we ask teens to report on their e-cigarette use. So these are all different kinds of things that we might consider. And then we communicate our findings in the media, to the public, to healthcare providers, to other stakeholders, to policymakers. That's all part of the role of what the bigger public health aspect might be. The next case. So we have a 62-year-old male with frequent urination. He comes to clinic with a month history of frequent urination and excessive thirst. A week previously, he was evaluated by a urologist who found no bacteria in the urine and no signs of BPH or benign prostatic hypertrophy on exam. His symptoms did not improve, so he's coming in today after some basic lab tests. His medical history includes hyperlipidemia. His family history includes obesity in multiple relatives, heart attack in his father, and stroke in his mother. He reports no surgeries and takes a statin. His A1C comes back at 7.5. What's the diagnosis? And I imagine in the chat, you're all saying diabetes, diabetes. It's clearly diabetes. It is indeed diabetes. However, the question for a lifestyle medicine healthcare provider, again, it asks about what do we do next? And while medication management may be a component of the treatment, we're also then prompted to discuss and focus on nutrition. So we might say, has your eating patterns, have that changed in the past, couple years, is that why we're starting to see this? And maybe they'll say, well, I recently got divorced. My partner used to make the meals. I'm no longer, making the meals. I'm buying things that are processed, and that is the reason that now we're seeing the change. Well, we can work through that. We can talk about meal prep. We can try and help that person and partner with them to see what changes that they want to make there. Or maybe it's physical activity. They were walking around their neighborhood each night. There, a couple months ago, there was some gun violence around their block. And so now they're no longer walking and they don't know where it's safe to walk. Maybe we can suggest, where is it safe for you to walk? Are you able to walk when you're at work? Are you able to do some walking around the mall, indoors at the mall? Where can you do that physical activity? And how can we partner with you to make that happen? Maybe we talk about sleep. This may be a person, they just got a new job and it's very stressful, has them up at night. They're having maybe more anxiety. How do we help address those things so that they're sleeping better and they're able to make, different decisions about what they're eating, what their exercise is, or even just the sleep itself when you're not having good sleep could affect your body's regulation of sugars. Similarly, as we talk about stress and what stress levels are and what changes in life might be leading to those stress. Substance use, perhaps the person, started to drink more alcohol and why, so these are all different things that we can ask about and delve more into to better understand. It's not just, this person has diabetes, we start them on metformin and then we say good luck. Or even, sometimes, we're able to set them up with nutritionists, and that can help to an extent. But there might be a role for, particularly for lifestyle medicine physicians, to delve deeper into all of these different areas and to help better understand what is the root cause. And so that's the reason that I also put, you can see the image of the sink. And that's a very public health kind of thought, is that, when there's a kind of a story of the water flowing and people taking buckets and bucketing out the water and trying to move it away in order to prevent the flooding into a certain area. And in public health, instead of taking the bucket and trying to bucket out the water, what we try and do is we look upstream and we see that there's a faucet that turned on. So we turn off the faucet. And similarly, so with diabetes, what we'd want to do is stop or halt or address the root cause rather than just treat the manifestation at the end. So you might be able to employ motivational interviewing techniques for change management, address root causes, social determinants of health, use SMART goals, which are goals that each of those letters stand for a particular thing that help you to form goals that are actionable. And you might consider connecting the person to support groups. If say they're struggling with diabetes, there might be other people that are struggling with diabetes. You might be able to, if there's support groups in the area, or that might not just be for diabetes, but for smoking, for other things as well. And our third and final case. So in Spain, a 38-year-old male presents with a rash. He came to clinic with multiple pustules on his arm, on his palms of his hands, his arms, his legs, his torso, and genital area. He mentions that he was recently sexually active with a partner he met on an anonymous dating app. He has a medical history of HIV and previous syphilis diagnosis. He was screened for STIs and gonorrhea result came back positive. He reports no surgeries and takes ART therapy. Viral load is undetectable. What is the diagnosis? And everybody in the chat is saying, I think it's monkeypox. Very good. But again, we want to ask, well, what do we do next? Diagnosing one person. Okay. We diagnose with one person. And of course, that's important. We want to test the patient for monkeypox. We want to potentially treat the patient with TPOXX if they're eligible. Of course, we also want to engage in pain management. So there's many over-the-counter kinds of treatments that can help with monkeypox, and ways that we can help with relieving pain and helping people when they're in the outpatient setting, or TPOXX if they're eligible. But we also want to discuss isolation because of the possibility of the disease spreading. And we want to, from the public health side, also enact contact tracing to evaluate for exposures in partners and need for post-exposure prophylaxis. We want to set up systems for vaccination in the community. and set up systems for laboratory testing and partner with healthcare systems for TPOXX treatment and educate the community regarding harm reduction strategies, as well as healthcare providers about clinical considerations, and then connect with community partners to better understand equity concerns and need for resources out in the community. For instance, for people who are on isolation for weeks, and therefore if they're in isolation, they may lose their job, or they may not be able to work, then they may not have money, so they're not able to afford for food or for other things that they might need. And then the other role is advocating for additional community needs, the needs that the community might have. So just that dimension, that clinical treatment is just one dimension. And I think that we're fortunate in public health and preventive medicine, lifestyle medicine, one to address root causes, but then also to look at the larger population aspects and to try and help to address those in a much broader scope or broader arena. And so that is the end of the formal part of the presentation. So I will pause for Q&A.
All right, well, thank you so much again, Dr. Chevinsky, for all of that information. It is a new specialty to virtual shadowing here. We have quite a few questions, a lot of questions. Hopefully we'll be able to cover them, but I'll just go in order. The first one is about residency. How long can that be? And you mentioned the general residency being preventive medicine. You mentioned some subspecialties, occupational medicine, and others. How difficult is it to match in those residencies?
Okay. I'm going to just check because I think my internet. Are you able to hear me now?
Yeah, we're able to hear you.
Okay, perfect. So I think what I heard is the first question is how long is this specialty? And then the second one is how easy or difficult is it to match? So is that correct? So
Yeah,
for the first question, if you're doing the categorical approach where you're going straight into preventive medicine, that would be 3 years. And it's similar to like pathology or radiology where you're doing a 1+. So you would do the transitional year or you do a prelim year and then 2 years of preventive medicine. So that would be the training. As I mentioned, some people, they might do different residency first. They might do family medicine and then preventive medicine, or pediatrics and then preventive medicine. And similarly, preventive medicine, occupational medicine, those are all the same amount of years. In terms of how hard is it to get into preventive medicine, it's a specialty that I think it relies more on showing an interest in that field. So for those, because there are less programs in preventive medicine than there is like family medicine or pediatrics or something like that. There are fewer spots, but at the same time, it relies more heavily on showing interest and experience and passion around preventive medicine and those areas of public health, rather than necessarily as strict guidance around, say, step scores or I guess now you guys are switched to pass fail. So maybe you don't have to deal with that at all in my day, step scores. But just to say that it really has more, from what I've experienced, more of a holistic application process where the reflection is on the want, interest, and passion around preventive medicine, more so than perhaps other factors.
Another student asks, and this student is interested in taking an MPH. They're interested in public health in general, but they're just not sure if they want to pursue an MD to actually treat patients. So they ask the question, what role in getting an MD and an MPH did it play to now being in your current position? Yeah, so there are certain avenues, there's certainly avenues into public health through getting an MPH. So it's not to say that this is the only route or even that MD is the only route. Certainly we have people in public health that are from a range of different kinds of clinical backgrounds. So PAs, nurses, physical therapists, there's certainly a range. And there are those that have MPHs that don't necessarily have the clinical background quite as much. And they're all value members of public health. So I think certainly all of those can. I think it's looking at what to you is most of interest in public health. If you're wanting to, treat
patients, then you might be more inclined into the realm of taking more of the clinical route and then the MPH, or there might be a consideration. I certainly know people that have not done preventive medicine, but they've done an MD, or they've done a different clinical degree with an MPH, and then they work in public health as well. So I think that one, it takes a little bit of a reflection in terms of what area in public health you would want to be, and whether what level of leadership responsibility you'd want to take, and if that's more operational or clinical. So for instance, like the director of our public health department, and I know many public health departments are not MDs, or they're not necessarily nurses, or, there's definitely the different career paths into public health that also involve leadership. It just might look a little bit different, and may have more of a focus on logistics, or on epidemiology, or on some other core knowledge area that then gets that gets pulled in.
Another student asks 2 questions. The second one is the same as the one we heard earlier, but the first one is different. How long did it take you to get involved in these big public forums, on these platforms, and to be able to reach these audiences?
So in terms of the public platforms and these audiences, I imagine they're talking about like some of the rotations and things that I was doing. Or perhaps if I don't properly answer your question, please ask it again in the chat in a way, and then I'll respond. But from my understanding of the question, involvement in some of these larger platforms. So I had been interested in some of these areas since I was in college, or since or I would say, yeah, even at that time I was blogging. When I was in medical school, I was running a bioethics tweet chat. So it was always something that I was like interested in connecting with larger communities. And so that happened in different ways. But I guess I would say that happened, yeah, all along the career path and training path. And so I hope that is also an empowering message to those that are listening, that there's a lot that you can do at whatever stage you are as a student. And I think a good example of that is, this group in itself that is bringing, virtual sessions to people, that there's many different creative ways to reach audiences, large audiences. And it just takes a little bit of innovation and passion and stick-to-itiveness.
Yeah, definitely. Grit, passion, drive, all of which have contributed to this. In fact, on that same note, a student asks, and this is something that we often will bring up, no matter the specialty, it really carries on from one to another. They're interested in specifically international public health, and they're just wondering, how can they get themselves involved, even as a pre-med, even as an undergrad student? Where could they find opportunities to get involved in international public health so that they can explore, gain exposure, see if it's right for them?
Yeah. So there's certainly a lot of volunteer and nonprofit kinds of organizations. What I would say is for me, when I was looking at some international experiences, what I wanted to see is that there was a consistent presence on the ground. So unfortunately, there are some programs, and it's not meant to call any specific one out, but it can actually cause at times more harm than good if there's a program that comes into a place, does a couple weeks of help, and then leaves, and kind of then the system isn't necessarily set up to continue with that same level of care. So I would say you can certainly look online for different programs. If you're at university, you can talk with your study abroad coordinator and see if there's any programs or opportunities that they know of. And then you can also look at the American Public Health Association website. They might have some connections and resources around international programs. Of course, I think things have been a little bit more challenging with COVID, and that has probably affected a number of different programs. So I can't really speak as much to that. But I would say when you are looking at programs and when you're searching and when you're talking with people, try and find those programs that have some presence, that are on the grounds in those areas consistently, and that have that kind of what I would call local expertise. So somebody who's either lived there, worked there for a long time, is very familiar with the community, that amplifies the community voice in that place, such that it's not a destabilizing force, but rather a force for good and for help.
One student asks, you mentioned preventative medicine, lifestyle medicine. A student asks about the difference between lifestyle medicine and holistic medicine.
Sure. So holistic is, I guess, a broad term to talk about like a whole person or evaluation of multiple different kinds of aspects. And while there might be some crossover between lifestyle medicine and the concept of holistic medicine, lifestyle medicine itself does have like a medical board associated. So for instance, I sat for that exam and got board certified. And it focuses specifically on those 6 pillars as the core. There are other things that cross over into similar topics or might have some crossover. So you mentioned holistic medicine. Another one that you might hear is functional medicine, or the what's it called? Like other health system practices, like Chinese traditional medicine or Ayurveda, or things that fall within the traditional medicine versus more of the complementary and alternative medicines. That's what I was trying to think of. And so each of them have their own focus, I would say, or their own specific area that they try and more heavily amplify. For lifestyle medicine, what the idea behind that is looking at evidence base for specific things that people can do within their typical life patterns that have been linked to improve health. But there's certainly crossover. Some people might say that lifestyle medicine is a form of holistic practice. Some people might say that holistic practice might fit into lifestyle medicine. So there are different lenses to look at it with. And similarly, so some people that work in primary care, they might say, well, how is lifestyle medicine different? And I think there's just, it's just a focus different in some aspects for these different things, but of course, a good amount of crossover too.
One student asks, in terms of your daily practice, how much of your job involves treating people versus prevention? So the whole theme being preventative care, lifestyle medicine, but do you come to the point of treating, or is that reserved for other specialties, other providers?
So with prevention, when we talk about prevention, there's primary prevention, secondary prevention, tertiary prevention. And so each of those play a role. So that might span the realm of trying to help promote healthy eating and physical activity, which is more of like primary prevention, or vaccines, or secondary prevention, which might be more like screening for disease, tertiary prevention when somebody's already diagnosed with something, helping to address that. So for preventive medicine as a whole, some people work more so on the prevention side, some on the management side. When people already have a disease, so that might be considered treating, but the prevention lens is the idea of reaching the root cause and working to prevent progression, for instance. And so for me personally, if you're asking about my personal breakdown in work and how and what I do, and like I said, it's different for different people in public health, different people in preventive medicine, different people in lifestyle medicine. For me, I have a clinic typically 1 day a week doing tuberculosis clinic where I'm individually treating patients with tuberculosis. And then in one location, and then 1 day a month in another location, 1 day a month and yet a third location. And that's just to make sure that we have good coverage across the county. And so it can vary from people having half day a week of clinical care, a day a week. Some people have, the majority of their week, especially if they're doing clinical lifestyle medicine. So it really varies based off of either the need of where you're working or your own personal interests. And similarly, it may range from doing mostly prevention kind of care towards doing more of the treatment and management.
There's a question that I think there's a lot to say in it, but hopefully we have some time to get around to it. On the same note, this student asks that a concern of many with the healthcare system that we have now is that it's motivated for largely financial reasons to have more patient visits, to prescribe medications, and generally target treatment instead of prevention. What shifts are we taking right now, and what shifts are being planned in the future to at least incentivize or focus more on preventative care?
Well, that's a large sweeping question, so I can't necessarily talk about what's happening at all levels, but I can say that preventive medicine as a field does line up with the idea of shifting things more towards prevention, trying to it's not only about keeping visits to be more outpatient versus inpatient, but really trying to help people be healthier so they don't even have to be in the clinical realm. It's not incentivizing people to be seen in clinical settings, but rather reaching people where they are out in the community. It's the idea of building parks and safe walking spaces and built environment. And so certainly that's efforts that public health departments are working towards to try and address health of populations. And depending on the model of different healthcare systems, there are efforts that are moving in that direction too. So some, for instance, managed care organizations where they're having to take on the cost of the entire, patient journey, there might be incentives or efforts to try and have more of a focus on prevention, or with certain kinds of accreditation or certain quality health scores for clinics or hospitals are linked to equality in certain areas, or HEDIS measures or other measures like that rely on some of those positive indicators of trying to prevent. So showing that they're screening a certain number, X number of their patients for certain diseases, or that they're catching diseases early. So there are efforts underway within healthcare systems, nationally, and within public health to make those shifts. And certainly, if that is the way that you are feeling, preventive medicine, public health might be an area that you want to look into.
The student from earlier who asked about larger or a bigger platform that you can work with, they were referring to working with the CDC, the Senate, platforms like that.
Well, so with the CDC, that was, as I mentioned, the initial entry point was as an epi-elective student. So I was in medical school and I applied for the rotation. So I think it's, putting yourself out there, looking for the kinds of areas where you want to be and seeing whether you can do internships or training opportunities. When you're a student, it's really actually a very key time where people don't want to say no to you because they want to be able to teach you something. They want to be able to help the next generation become, those that are able to lead. And so some of it is writing emails, some of it is looking for the opportunities. I think another example would be the rotation that I did with UNESCO. So that was when I was in college. I believe I started writing emails when I was in freshman year. I just looked up email addresses of people that were working in bioethics in UNESCO. And I started writing them and saying, I'd really like to do an internship in UNESCO in bioethics. And they said, now's not a good time. And so then I wrote them back when I was a sophomore. And I said, hey, remember me? I'd still really like to do a rotation in bioethics at UNESCO. And they said, well, I'm not sure if we can manage that. If there is, as you're coming, internationally, it may not be able to be coordinated. So then I wrote them again as a junior. And then they said, you know what, we think we could probably accommodate this. And so I ended up doing the rotation at UNESCO between my, I think it was between my junior and senior year. Oh no, it was for my junior year. That's what it was. For my one of my semesters. So I think it's having, I guess, the courage a little bit to put yourself out there and write those emails, and try to advocate on your behalf for some of those spots. Now, of course, some you might run into some red tape, or for every experience that I've had, I've probably had a few that told me they couldn't accommodate it, or that it wasn't possible. But not being discouraged and still doing those reach outs. And then I think the other part of it is trying to have it either be accompanied by some level of funding, or having it incorporated into something that's part of your university that you get credits for, something like that, to defray costs. Because I think that's the other part that can be really difficult as a student, whether in undergrad or medical school or another level, is if you don't have the funding, oftentimes these experiences can be costly. And so trying to find the scholarships and trying to talk with, say, like your study abroad office to see, is this something that they could cover underneath one of their programs? So looking for creative ways to match up funding with the opportunities that you want to do.
You talked about the lifestyle medicine certification earlier. A student asks, do you need an MD to get that lifestyle medicine certification?
So that's a great question. So the American Board of Lifestyle Medicine, they do certify for those that are not MDs as well. They have two different kinds of certification, but it's still a certification in lifestyle medicine. And so I definitely suggest taking a look at that. Even if you're not going the MD route, you can still get certified in lifestyle medicine. And that might be for those that are working as like health coaches, or that are interested in doing patient education, or are working in other realms. It's not just physicians that are getting some level of certification.
On the same topic as what lifestyle specialists do, what type of settings do they often find themselves in? Is it a certain niche? Is it really all across the board?
So some people work in purely lifestyle medicine clinics, where they work as like a specialist that consult, similar to how other specialists would. So where somebody would have their own primary care doctor, and then if they needed additional help with some of the conditions that they were having, they might be referred to a lifestyle medicine specialist. That's one potential model, or that exists. Some people that go into lifestyle medicine, they already have like I mentioned, preventive medicine, they might already have a specialty. So they might do combined preventive medicine, primary care and lifestyle medicine, where they're dealing with some of the acute concerns, the chronic concerns, and then also having more of a lifestyle medicine focus in their particular practice. Some lifestyle medicine physicians work in health tech, or with the newest gadgets that might help better measure whether it's blood pressure or glucose or whatever it might be. So there is a large variety of some of those that work in association with other clinics, or work independently, or are doing primary care at the same time, or some work in coordination with cancer hospitals or things like that, where there might be specific lifestyle needs that could be coordinated alongside the cancer care that somebody's receiving. Some people do more mental psychiatry and mental health and lifestyle medicine. So there are many ways that it's incorporated into practices. Some doing just core lifestyle medicine, and some doing it as an add-on or another component of the other kind of care that they're also providing.
Earlier, you talked about your career background, your education, going from UConn to Florida to now Loma Linda in California, kind of being on the coasts. do you feel like that's contributed to your career just with how you're able to talk with patient demographics? You've seen multiple settings and sides of healthcare across different states. Has it made any contribution?
I think it certainly has. As a person noticed, I've done a lot of moving with a couple of years here, a couple of years there. I was in, I'm originally from New Jersey area. And then, I was in Connecticut, I was in Pennsylvania, Florida, Atlanta, California, and then deployed to Chicago, other places. I definitely think being able to experience that can really help. So being at, I think there's pros and cons, of course, of any decision, and depending on life circumstances too. So for some people, they may decide that they want to settle in a certain area. And so they decide that they're going to do college in the area, medical school in the area, residence in the area, maybe fellowship, or whatever other training, and stay in that area. And I think there's it's all about a balance of what somebody is looking for ultimately in their life. Or somebody might have kids and their kids are in school, and it just makes them make it a little bit more challenging to move. So that these are different factors to consider. But for my personal situation, I do feel like seeing how healthcare is practiced in different settings, seeing how being exposed to a diverse group of different people and communities and populations definitely helped me to better interact in different settings. And I think with that comes a sense of, so you guys may have heard the term of like cultural competence. For me, I prefer to think of, and this is not my term, but it's a term that is in the literature that I appreciate, called cultural humility. And it's the idea of, we're not necessarily trying to be competent in somebody else's culture or their religion or their background, but having a humility around it to ask and try and understand, and availing ourselves to a number of resources to better understand, so we know the right questions to ask, but at the same time is not assuming, because just because somebody might affiliate with a certain group doesn't mean that they completely align either. So those concepts around intersectionality. So meaning that somebody might be part of a certain race group and have an identity with that. They might also have a disability that they identify with, or they might have a sexual orientation. So people are often multi-layered rather than, sticking to one certain thing. And I think, yeah, being in multiple different places, meeting different people, practicing in different settings definitely helps to understand it and continue to work in different settings.
Talking about moving a lot, is it possible, or is it a common thing that people involved in public health, people who take these residencies for preventative medicine, will go out internationally, not just nationally, but internationally, to help out like you did with various outbreaks?
So I don't know the percentage of people that do that, but certainly there's a large number that may do that. So with, for instance, CDC, they have some positions that are more domestic and some that are more international. With the international positions, oftentimes there are deployments, and even those people that work more domestically, there might be opportunities for deployment internationally. So for things like polio or Ebola or other things as they may arise, there are a fair number of people that work in public health. Some of them want to work more so in chronic disease, some more infectious, some more want to stay domestic, some more international, but those are all options that people can have. I think the other thing that people typically decide on is whether they want to be an expert in one specific area, or they want to sort of understand things more broadly across different domains. So for instance, you might find somebody who's in public health or preventive medicine that is the lead smallpox expert in the world, or like one of the smallpox experts in the world, or the one of the worldwide experts in polio. So somebody might decide to go down that path. Alternatively, somebody might work like similar to like in county health departments or things where you really have to learn a lot about many different areas, because there's more than one thing that might be affecting a population. And so people who are deciding their career in public health or preventive medicine often make that decision of, do I want to be more of somebody who covers many different areas and take on new things as they come? Or am I looking to really delve deep into one specific area?
I think we'll wrap up things with one more question unless we see any others that come in. That last one is, we see the CDC, county health departments like you're involved in as deputy, and just generally kind of governmental associations or organizations pushing this public health movement. Will there ever, or do you think that there's ever been a time, or has there been movements already in private industry to push that too?
To push the focus of
Preventative care in general.
preventive care. Well, I definitely think that that idea of prevention is so core to public health, and for ages it has been since, you know, the start of public health. The idea of prevention has been so core, looking at, you know, just maintaining proper sewage systems and so some of the things that have just started out really public health from the beginning. And so I think while that has come more into light recently because of a light being shined onto public health with the recent pandemic and some of these issues, it's something that public health has been doing for a long time under the radar. I always used to think of public health and the work of public health is like the work that keeps populations healthy that they never know about. So for instance, doing inspections in restaurants and making sure that the food is healthy for people to eat, that you're not going to get infected. You would never know necessarily that inspection happened, but it happened, and therefore that's why you don't get sick. Or checking on doing flu surveillance. Or going around in communities and seeing if there's large pools of water that might attract mosquitoes and trying to address those so that way vector-borne diseases like West Nile virus don't spread. So things like that you might not know is happening in the community, but are happening to keep you safe. Now things have shifted a little bit and it's come a lot more into the public eye. And so I think you see that a bit more. In terms of private companies and what their shifts may be, I think it just, you know, it depends on the company. I think we have seen more like companies that are investing in lifestyle medicine kinds of areas, or, you know, as the pandemic was happening, certainly those that were focusing on how to address COVID through many different ways. But I can't, you know, in terms of shifts overall in private companies or private sectors, it's hard for me to speak on that part of it.
All right, well, a lot of questions, a lot of insight, and I'm glad that we had this as our first for preventative care and lifestyle medicine. Hopefully we'll see more subspecialties along the way, but thank you again, Dr. Chevinsky, for joining us. It was such an insightful session, so helpful and honestly inspiring. I learned a lot. I'm sure the same for many students here listening. They can say the same. I do want to give a few reminders to those who are listening in, particularly if you're new to shadowing. So for our shadowers, to earn credit for your attendance, you must pass the quiz to receive a certificate. This quiz is with a passing grade of 60% or higher. There are 10 questions, so get 6 or more right and you're good to go. We've posted that quiz in the chat box and it's also available on our website under the virtual shadowing page. The quiz will be due next week at 11:59 p.m. Central Standard Time, this upcoming Wednesday, August 17th. After passing that quiz, you will receive a certificate sent to the inbox of the email address you list on the quiz. Just in case you don't receive that certificate, feel free to shoot us an email or please check your spam folder. Our email is included in the video description. We now include quiz links and our email. It might be there, but just in case it is not there, our email is going to be shadowing.h4h@gmail.com. I'm not sure if it is, so just in case, make sure to note it down, just in case you have any questions or you can't find your certificate. For next week, our next shadowing session will be with Dr. Cyrus to explore orthodontics. It's going to be on Monday, August 15th. So stay tuned for that. Again, follow us on Instagram to keep an eye out for more shadowing sessions. We're going to be posting not only on our shadowing sessions, but also on our programs, which we've been now expanding ever since around this summer, going into this fall. They're going to be soon launching. So you'll want to stay tuned with those. Outside of that, that's all I have to say. Another way to keep in contact with us is our listserv. So either way works, whatever you find best, whether it be Instagram or our email listserv. Those are the two great ways to stay in touch with us. Outside of that, I think that's all. I really do appreciate your time, Dr. Chevinsky. I hope everyone here has learned a lot. And yeah,